Assalamu alaikum. Welcome to the final episode of cutaneous vasculitis. In the previous lectures, we discussed large, medium, small, and single organ vasculitis. Today, we will have a look at the vasculitides that may affect more than one vessel size simultaneously, and also vasculitides that are believed to be secondary to systemic disorders or drugs. There are two disorders which can affect variable vessel sizes: Cogan Syndrome and Behcet's disease. Cogan syndrome is an autoimmune disease with autoantibodies against the Cogan peptide in endothelial cells and inner ear. It is not uncommonly associated with connective tissue diseases, especially polyarthritis nodosa, and this syndrome always presents with keratitis and audiovestibular symptoms. In more than 10% of patients, cutaneous vasculitis can be seen ranging from purpura to subcutaneous nodules. The multisystem Behcet disease is famous for affecting various vessel sizes and types. This results in a wide range of vasculitic lesions, to the extent that even classic lesions of Behcet like erythema nodosum, papillopustules, and non-genital ulcers may occasionally show signs of vasculitis or vascular congestion, at least in the early stages of development. Vessel involvement of medium and large vessels may lead to life-threatening aneurysm, occlusions, or DVT and superficial thrombophlebitis. Cutaneous vasculitis may be secondary to connective tissue diseases, drugs, or even infections. The most common connective tissue disease associated with cutaneous vasculitis is systemic lupus erythematosus, where it can manifest as ulcers, palpable purpura, or palmar erythemas. Antiphospholipid syndrome may also accompany systemic lupus erythematosus, leading to vasculopathy with livido and ulceration. Other signs of cutaneous vasculitis of systemic lupus may include nail fold and digital vasculitis, urticaria, and nodular lesions. Rheumatoid vasculitis occurs in patients suffering from rheumatoid arthritis and presents with palpable purpura, nail fold infarcts, digital necrosis, and even gangrene. Moreover, other types of vasculitis that we discussed, like erythema elevatum deuterum and urticarial vasculitis, are known to be associated with rheumatoid arthritis. Other connective tissue diseases may also be associated with cutaneous vasculitis, including Sjogren syndrome, scleroderma, and dermatomyositis. A few drugs are known to induce vasculitis, and those include tumor necrosis factor inhibitors, hydralazine, and thiouracil. In the past decade, the addition of levamisole to cocaine among drug addicts posed as a major cause of drug-induced vasculitis. For infections-associated vasculitis, almost any infection can be associated with the development of vasculitis of the skin. However, the frequently reported organisms may include the hepatitis viruses and the Treponema pallidum. Still, cutaneous vasculitis was reported with HIV, Staph aureus, strep, and herpes virus. Sarcoidosis is an often forgotten association with vasculitis. Patients with sarcoidosis may show signs of cutaneous vasculitis like livido, erythema nodosum-like lesions, subcutaneous nodules, and skin ulceration. This table summarizes all the previous lectures about cutaneous vasculitis, and it includes only vasculitic disorders with cutaneous affection. The most common physical signs are listed, as well as the most diagnostic tests, if any. Nonetheless, this is not a comprehensive list, but a simplified guide for easy recall. We should not forget that cutaneous vasculitis can be secondary to connective tissue disease, drugs, and infections. Also, the overlap between vasculitis and vasculopathy may pose diagnostic challenges, which hopefully we can discuss soon in a separate lecture. Thank you very much.